Acute bone loss, I think, is a little bit more of a straightforward problem. The bone is missing, but the biology, assumingly, is there. For treating a non-union, I think that it's a little bit different because we need to figure out the etiology of the non-union. Is the non-union there because there's been an infection the whole time? Is the non-union there because there's a biology issue? Or is it because there's a mechanical issue and not enough stability? And so in those cases, I think for non-unions that are just stability and it's hypertrophic and it just needs a little bit more, I'm not necessarily sure that a PABST is the treatment modality for that. But for somebody who has an atrophic non-union where I'm worried that there's bone biology issue, or maybe there's some bone necrosis, then I think those cases are ones where, hey, we need to do a resection of that bad biology bone and let's get good bone coming into contact with good bone that gives a better potential to heal.
So I treat non-unions and acute bone loss a little bit differently. It's fairly similar in some respects. With an acute bone loss, that patient's going to be in an external fixator, and normally I'm taking bone out during early procedures and replacing that bone with cement blocks. So the cement block is going to produce a membrane, which can be good to transport into, like kind of combining a mass delay technique with the PABST technique. In somebody with a non-union that's getting a PABST technique, a lot of times I'm not going to be doing the cement block. So that patient is going to have a bony resection. They're just going to get the bone transport, where the cement is going to create a membrane that I can transport through.
If there's concern for infection before we start, I really do not want to put any implants in if there's even a question of infection. It's a lot of metal that's going in the patient, and I think that that's something to be cognizant about. I want to make sure that there's no physical sign of infection, and if I am concerned, I'm checking inflammatory labs, and I'm also doing multiple tissue samples for culture. And I would like those cultures at least to be an antibiotic protocol in place prior to us doing anything, prior to us implanting any metal.
To try to prevent infection in my patients, it starts with the initial debridement. So taking out any devitalized tissue, taking out any foreign material. After that, if I'm placing them in an external fixator, I'm usually putting a polymethyl methacrylate cement spacer in. That does a couple of things. One, it keeps the bacteria away. Two, it maintains the length of the bone I'm trying to salvage. Moving down the line from the initial treatment on that patient, when I've performed the PABST procedure, I've found that the defect that you're filling in with the bone transport usually fills with blood, so that's hematoma that can easily get infected. It's usually underneath both your surgical wound and the patient's traumatic wound, which makes it a site that bacteria are going to colonize very easily. So I've started putting a calcium sulfate bead in that defect, and I found that as you're transporting your bone into that, that's dissolving at about the same rate that you're going to transport into it. So usually that will last about as long as your transport's going.
So inevitably, the vast majority of these patients have some type of temporizing external fixator prior to us going in and performing the PABST case. And so to me, setting myself up for success as far as an alignment is concerned is really having a good external fixator on, because we'll be able to use that in the operating room in order to help with our alignment. The good thing about using a PABST technique is that the plate that you're going to use is going to help with your alignment more so than, say, circular external fixation, because the plates are already pre-contoured, and so the bone can only go in so many different positions, and so you can really get the alignment. The more difficult thing sometimes is making sure that your length is correct, because once you put the plate on and once you affix it to the bone, your length is static. The length doesn't change, as opposed to a circular external fixator where you may be able to have that option to adjust limb length or adjust for limb length discrepancy later on.
Preparing for good alignment, like everything else in this procedure, starts with planning. So planning and also placement of your devices. So you've got to get your nail started in the right place, going in the right direction, in order for the intercalary segment to go in the right direction. When I'm doing this in a tibia, I always use a medial plate, and that prevents drift in the medial direction. So if you think of the lower leg in kind of mechanical terms, you've got your fibula on the outside, the tibia is on the inside. So if you use an anterolateral plate, you're not going to prevent that intercalary segment from going medial. So for that reason, I place the plate on the medial side of the bone. And then at that point, the only thing that I really have to worry about with drift is in the anterior or posterior direction, which is controlled mostly by the start point of your nail.
So blocking screws are important to me because I know that even with good fixation in the plate and good interlocking screws in the precise nail, the risk and the chance of deformity during the transport is still high. I say that because I've been burned before where I thought I was going to be fine and end up having to deal with deformity later on. So for me, if I don't use blocking screws during the nail placement, once everything is said and done, the last part of my case is I'm putting blocking screws both medially and laterally, and then usually anteriorly and posteriorly around the short segment where the nail is. For a PABST case, planning to me is everything. These are not cases that we're just gonna go haphazardly into the operating room and think we're just gonna figure it out when we get there. These are ones that I've thought about time and time again. I usually will show my partners and make sure that I'm not missing anything and that if they have any bits of information that they can give me. And so this has been a very well thought out planned case for me. So in this model here, we have what I would consider to be a critical size segmental defect of the tibia. And so the first thing we need to plan on is, am I going to have this plate be distally based, meaning it's more of a pilon plate, or am I going to have a plate that's going to be more proximally based as if it's going to be a plateau plate? That's going to change the stability of the construct. Additionally, in a tibia, I need to figure out, am I going to have a distal corticotomy or am I going to have a proximal corticotomy? Am I going to have a proximal corticotomy and I'm going to push this segment down, or am I going to do a distal corticotomy and I'm going to pull this segment up? To me, that all depends on the location of this defect, where it's going to be, and what plate I'm able to use. So in this example here, we have a distally based plate, more or less a pilon plate, that's going to span this entire defect. We have the magnetic nail, the precise nail is going in and is fixed here. This bony segment here is only affixed by this interlocking screw here. The corticotomy or the surgical bone break is down here, and so in this case we are going to do a retrograde transport. We're going to pull this segment up, regenerate will form here, and this segment here will close down until these two bone pieces dock.